It Takes Balls is brought to you by our new sponsor, D's Nuts. Yes, you heard that right. If you've never heard of them, check them out at grabdsnuts.com. But warning, these are not your grandparents' peanuts. D's Nuts is really shaking up the nut game. They're gourmet, fun, and packed with flavor. Whether you're a fan of savory flavors like ranch, sriracha, or hot cheddar, spicy like ghost pepper, or if you have a sweet tooth like me, you'll like the banana pudding. D's Nuts has something for everyone. But D's Nuts aren't just about taste, they're about making a difference. For every bag, can, or piece of D's Nuts merch purchased using the coupon code NUTCHECK on grabdsnuts.com, you can save 10%, and another 10% gets donated towards supporting Testicular Cancer Awareness Foundation. So the next time you're craving a snack that's both delicious and meaningful, reach for D's Nuts. Because when it comes to supporting Testicular Cancer Awareness Foundation, it takes balls and it takes D's Nuts. Available at grabdsnuts.com, Amazon, and Walmart locations nationwide. D's Nuts, a delicious, healthy snack in a variety of fun flavors and making a difference one nut at a time. The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. We're halfway through Testicular Cancer Awareness Month. This is episode 50 of the podcast. Shout out to us. We did it. You might have noticed something different about the intro, and that is the theme song has changed. That theme song is now called No Time Like Now. I had kind of gotten tired of the old theme song, which was just a royalty-free something from a website. So we held a contest on Testicular Cancer Awareness Foundation socials. So if you're not following us, make sure you're following. And Tom Wilner, along with a few other applicants, submitted, and Tom won. So No Time Like Now is from his play Having a Ball at 30. We'll be talking to Tom in a few weeks on the podcast. So really excited for that. But today I've got board certified, fellowship trained urologist, director of sexual and reproductive medicine at IU, and assistant professor of urology at IU School of Medicine. Dr. Helen Bernie, thank you so much for being here.
Oh, thank you so much for the invitation. I'm happy to be here.
So I sent you a bunch of these questions beforehand, but from the support group. Testosterone is a big thing on our online support group. But before we get into all those questions, what is testosterone?
No, so great question. So testosterone is prevalent in men and women. And in men, testosterone is really our principal circulating androgen, with about 90% is going to be coming from the testicles and about 10% is made in your adrenal glands. Now, how our body makes testosterone is that we have LH, or luteinizing hormone, which is actually produced by your anterior pituitary gland. So it's up in the brain. And what it's going to do is it's going to stimulate the testicles to make testosterone. Most men and women need both testosterone and estrogen. And actually in the body, testosterone levels get converted into what's called DHT, or dihydrotestosterone, and estradiol. So it's actually really important for all of those. So testosterone and estrogen are actually important for both men and women.
Interesting. Okay. Another question I had before we get into these other ones is, what are the differences between total and free testosterone?
No, really good question. So your total testosterone is the total amount of testosterone in our body. Now, a lot of that testosterone gets bound to proteins, or what's called sex hormone binding globulin and albumin. The bound testosterone is not active, meaning it's not able to be active in our body and give us the side effects and the results and the symptomatology that we have from testosterone. So free testosterone is what is not bound in the body, circulating freely, and that is what is actually going to be what's active in our body.
Okay. And I know when I've had mine drawn, like, it always has to be done in the morning. So what's the reason for that?
Yeah, it's a really good question. So testosterone needs to be drawn in the morning because it's diurnal, meaning our body kind of restores and makes testosterone overnight. And so it's going to be highest in the morning in both men and women. And then it slowly declines throughout the day. So when we're looking at testosterone levels, we want people to get them early in the morning because that's going to give you your best testosterone level. And that's going to let me know that, if that's low early in the morning, then I know throughout the rest of the day, it's just going to decline further and get lower and lower, which is important. And it's supposed to be that way so that at nighttime we're sleepy and we're more tired. And so you want your testosterone levels to go down when we sleep. But that's also why it's important to get good sleep, because testosterone is going to be restored during our REM sleep, or our REM sleep, that important sleep where we're dreaming.
Interesting. Okay. All right, let's get into these questions. So Christopher asked, what are options other than testosterone? He was surprised at the conference, which you spoke at, to hear about the possibility of Clomid to boost testosterone. And what are the side effects of Clomid?
No, really good question. So I use Clomid a lot. Clomid is a selective estrogen receptor modulator. So what that means is it's going to block receptors for notifying that we have estrogen. So kind of how I mentioned earlier, in our body, testosterone gets converted to DHT and to estradiol. So our body is really smart and it works in a negative feedback. So when estrogen levels get high, it says, whoa, let's put the brakes on making testosterone because we have enough estrogen, and vice versa. So when our estrogen levels are very low, it says, hey, let's make some more testosterone so that we can have that converted into estrogen levels that we need. So what a selective estrogen receptor modulator does, or Clomid or clomiphene citrate, different brand names for it, is that it's going to block estrogen's receptors. So our body thinks that we don't have enough estrogen. So then it's going to stimulate the testicles to make more testosterone. So we use this very commonly. I use it in all men. There's not really anyone that I don't offer it to, aside from maybe patients that have already been on exogenous or outside testosterone. But Clomid is a wonderful option for young men that are still interested in fertility, that want to increase their testosterone levels or already have low testosterone levels, because it stimulates your natural testosterone production. It's not bringing in testosterone from the outside. And because of that, it doesn't impact sperm production or spermatogenesis. So in men, we even have intratesticular testosterone, which is important for sperm production. And if someone takes exogenous or outside testosterone, our body is so smart, it's able to say, hey, I have enough testosterone, but it doesn't know where it's coming from. It doesn't know that you're taking it from the outside or that it's coming from your own body. So when you have enough of something, the body says, all right, let's put on the brakes. We don't need to make anymore. And so it suppresses testosterone production in the testicles. And while our body's smart, our testicles do two things. It makes sperm and it makes testosterone. So when you suppress one, it suppresses the other as well. So Clomid is a great option for men that are still interested in preserving fertility, or in men that just want to try an oral route for increasing their testosterone therapy. Another option that we can give to young men besides exogenous testosterone, or men in general that are interested in fertility, is something called HCG, or human chorionic gonadotropin. And that's our hormone that stimulates the pituitary to make LH, which stimulates our testicles to make testosterone. So these are all really important things.
Interesting. Yeah, that's great that there's options for like guys who want to still have increased chance of fertility.
Absolutely. Oh, and I forgot to mention, so side effects. Clomid is actually usually really well tolerated in most men. The most common side effects of Clomid is that you can get something called gynecomastia, and that's where men develop kind of breast tissue or man boobs. And you can get nipple sensitivity, or some people will say, like my nipples kind of hurt or they feel uncomfortable. Those are usually kind of the most common side effects. Some people can include talking about maybe a headache or some facial flushing. Less common, you may hear someone say they feel a little bit of nausea, or maybe some blurred vision. But another thing that is really important to think about whenever someone's starting Clomid specifically is that if you already have elevated triglycerides, then this will cause them to increase more. So you just need to be cognizant and think about what someone's lipid panels, or have that drawn before you consider starting them on Clomid, because our triglycerides are really important fats in our body and lipids in our body. But if they get too high, they can actually cause pancreatitis and other things like atherosclerosis in our arteries, and we don't want that stuff. So just really important to kind of check those levels too.
Is Clomid designed for this purpose, or is this like a secondary thing that was found out?
Very good. Yeah. So it's used off label in men. It's actually most often prescribed to women to help regulate ovulation, so that when they're trying to conceive.
So you're an expert in this field, but if somebody goes to their like just Joe Schmo urologist and they ask for Clomid and they get pushback, like what options do they have?
I think there's definitely a lot of physicians and providers that don't feel comfortable managing testosterone, or they're not familiar with it. If you have someone who's very open-minded, you could certainly, Google on PubMed Clomid for hypogonadism or low testosterone, and there's a lot of publications that they could bring to show their clinician. They could direct them to websites like the AUA, the American Urological Association, or the SMSMA, which is the Sexual Medicine Society of North America. And there's many articles that are on that as well. But I think certainly you could bring some articles. We have plenty and show that to your physician, or you can look online and find someone who maybe a urologist who's a men's health expert, who's more comfortable and has a lot more experience managing this, that can prescribe that for you. I tend to find people do better doing things that they're comfortable with and what they know about. And that also ensures that you're really going to be managed correctly, followed correctly with labs that you'll need to get and stuff like that.
Interesting. Okay. I'm just a patient, but I'm on like urology Twitter somehow, I guess, because of this podcast. But so who is like the right one for testosterone? Is it a urologist or an endocrinologist?
That is probably a good debatable question. At my own institution, everyone sends me testosterone, even a lot of the endocrinologists, because they aren't as comfortable managing it, or they don't want to manage it. Maybe their focus is more on diabetes and managing the endocrinologies of thyroid disease or things like that. But either one, you could certainly approach either one depending on your location and where you are. But urologists should be very comfortable. That's kind of our wheelhouse, right? Especially as men's health experts. This is something that we can do. This is something that we're comfortable doing and that we can do well.
Cool. All right. Denise asks, how does she feel about the mid-range for testosterone levels? Isn't it like with thyroid levels too large? Somebody can test in the normal range, but be functionally in need of treatment with testosterone. Why aren't more men treated who have a sagging testosterone level?
So I think that's a great question, Denise. If we look at just the range of testosterone levels, depending on what lab you go to, the reference ranges are typically anywhere between 300 and, 1,000 or 300 and 900. And so the AUA, or the American Urological Association guidelines, they recommend when you treat men to have a trough range somewhere between 450 and 650, which is kind of a mid-tier range. That said, I don't know what your testosterone level was, right? I don't know what someone's natural baseline was before they either had testicular cancer or before they maybe lost a testicle, or just through the natural process of aging, right? When they're 60, 70 years old, your testosterone may not be exactly where it was when you were in your 30s or when you were in your 40s. So I think that's just a good reference range, right? It's a good reference range to give us a testosterone level that should preclude you from developing, the worst or the terrible side effects of low testosterone, which can preclude to heart disease or cardiac disease, stroke, osteoporosis or brittle bones, in addition to metabolic syndrome or diabetes, because testosterone is so important for so many things in our body. It's not just for, energy levels and motivation and erectile function or libido, sexual health, but it's also really important for building muscle mass, for our bone health, for our insulin activity in the body to control metabolic syndrome and diabetes. So again, I think it's just more of kind of a reference range. We do have literature that does show that below a certain reference range, you're at higher risk for developing cardiac disease or osteoporosis. So, and the AUA guidelines recommend that hypogonadism or low testosterone is a level below 300 nanograms per deciliter with symptoms. So someone that has a total testosterone less than 300 that's complaining of fatigue, decreased energy, low libido, any of these things. So I think, how do I feel about mid-range? I think it's a good reference range to make sure that at least someone's total testosterone is not too low that could lead to side effects that we don't want, that we just talked about. But it's not this say-all, be-all. I think you can kind of look at the patient. You can look at other objective markers, like how are they feeling once you've started them on the testosterone? Do they have any other risk factors? What's their vitamin B12 level? What's their thyroid level? All of these things, what's their sleep habits, all of these things that can play a big role in how someone's energy is and how they feel, not just by going by a number, right? Treat the patient. Yes, someone can test in a normal range and need testosterone. I think that's more common when you see someone that has a very low free testosterone. And that's still a new concept, even for some urologists do we look at free testosterone or do we look at total testosterone? The current guidelines for the AUA recommended treating total testosterone because there was just insufficient data to suggest that free testosterone was better. But I think there's a lot of urologists now that are really going by free testosterone levels rather than total testosterone levels. And I think, again, people that are on testosterone or have levels, let's say, let's just do a really good normal 650, 700. If I see someone with that level and they tell me, doc, I'm still feeling really crummy or I don't feel any bit better, then again, that's usually going to trigger to me to say, let's look at some other causes because your testosterone is great. But a lot of the symptoms and side effects of low testosterone are multifaceted or multifactorial, which can be signs and symptoms of other things that can be going on. If your thyroid levels are low, if your vitamin B12 level is low, if you're not getting good sleep, or worse, if you have obstructive sleep apnea, if someone snores a lot at night, maybe they need a sleep study because oftentimes it won't matter how much testosterone we give you or how much we put it in a normal good range. If you have untreated obstructive sleep apnea and you're not getting good rested sleep, you're going to wake up feeling tired and you're going to wake up feeling fatigued. And not only that, but untreated obstructive sleep apnea can predispose you to stroke and increases pulmonary hypertension. So again, all things that are really important and that we want to look at as men's health experts. The last question was, why aren't more men addressed who have low T levels? Again, I think this just goes due to kind of education, getting people more comfortable with dealing with testosterone therapy in general. I think previously, just like with women and menopause, it was thought that, as a man gets older, this is just normal. Or as a woman ages, it's normal to go through menopause. It's normal to have these symptoms. And we're finding now that it's not normal and you don't have to feel that way. But testosterone is a good marker for overall health. And when someone is healthy, meaning they don't have a large number of comorbidities like diabetes, high blood pressure, high cholesterol, obesity, smoking, all of these things, when you're healthier, then they tend to have more normal levels of testosterone, even as they age.
So kind of in like the question of the range, like I didn't have my testosterone tested before I had my testicle removed. Would it be normal to have like my testosterone be doubled when I had both and then like halved when I just have one? Or is it true that the other one picks up the slack?
So really good questions. When I was in medical school, that was what I was taught too. I was taught that if a man loses a testicle, you have two of them. And so it's going to pick up the slack and you're going to be fine. But we actually see that that's not necessarily the case. So in young men that are prepubertal, oftentimes if they lose a testicle before they hit puberty, that other testicle will grow bigger or it will do what's called hypertrophy. And it can pick up the slack and it can help with producing that extra testosterone that you need for your body. But, the incidence of testosterone deficiency or hypogonadism in like cancer survivors is about 15%, especially those that have undergone chemotherapy or radiation. And that risk is notably going to be higher in patients that have a history of testicular cancer, with data showing that there's incidences of about 40% of testosterone deficiency or hypogonadism in men that have a history of testicular cancer. So, it is recommended, and those of us in the field always recommend checking a testosterone level before and after. But I think what happens is a lot of times someone comes in with a testicular mass, and these are young, healthy guys, and we want to rush you to get that out. We want to take good care of you. We want to get that cancer out as quickly as possible so that we can figure out what type it is and know what's the next follow-up and next treatment. So I think sometimes it's just not common that people get that. They certainly get tumor markers, but again, with more education, with more data, with this podcast, hopefully people will hear this and they'll say, hey, I should start adding that to my tumor markers and I should start getting a total testosterone level before and then after in my patients. Because someone that has two testicles, that has a 800 total testosterone level, that undergoes an orchiectomy, and now their follow-up is 450, which is technically in the normal range, they're going to feel dramatically different at a testosterone level of 450 than they probably did when it was 800, right? So I think that these are just things that we need to think about and bring more awareness to, specifically for testosterone levels. There was a study that looked kind of at developing, kind of an algorithm or a guideline for this. But unfortunately, I think in order to do that, because there is so much variation too with young, healthy men, some have total testosterone levels 450 and they feel great. And then others have it in 750. I think it would be really hard to say, that this is a strict cutoff. So I think that's kind of why we, again, have these guidelines for numbers to hopefully, put your testosterone level on a normal level that won't result in side effects of low testosterone, but also make you feel good.
Yeah. All right. The next question, we're kind of kind of be jumping around here just because I'm asking them in the order they were asked. But John asked for natural ways to boost it. And we did an episode with Dr. Gio Espinoza. He mentioned like weightlifting.
Wonderful.
He mentioned like heavy weightlifting and stuff. Anything like that from your perspective?
Yes, yes. So weight loss is great because obesity in and of itself, so people that are more obese will tend to have lower levels of testosterone. And that's really a link because in your body, adipose tissue or your fat tissue can actually convert testosterone to estrogen by an enzyme called aromatase that is found in our adipose tissue. So the more fatty cells you have or fat tissue, the more aromatase you're going to have in your body and lead to greater conversions of testosterone to estrogen levels. So it can lower your testosterone levels. There is tons of studies that have shown that weight loss is an independent predictor of increased testosterone levels. So weight loss, lifestyle changes should really be the initial approach that I tell everyone to do. But that said, if your testosterone level is extremely low and you're losing muscle mass, you're tired, you're fatigued, it's really hard to tell someone, go to the gym, go work out, go do all this stuff when they feel awful and they have low testosterone. So I treat these patients because number one, if you have normal testosterone levels, you're going to be much more likely to have that energy. You're going to go to the gym. You're going to be more motivated. It's going to help you put on lean muscle mass. So, I'm a huge proponent for treating patients, but it should also be done in the same consultation with losing weight, incorporating healthy lifestyle habits. We know that even weight loss is in a dose dependent and exercise is dose dependent for increases in total testosterone, meaning we looked at studies where the more you exercise, the greater your testosterone level can increase. But on average, most studies will show that if you lose weight, you can increase your total testosterone levels on average about 100 points. So in someone that has very low testosterone, that's maybe 150 nanograms per deciliter, you're looking at maybe bumping that up to 250, 150, 250. Maybe if you're really lucky or overachiever, maybe we can bump it up in a particular person to 350, but that still may be low for that person. And that person may still have symptomatology related to that. And so, yes, lifestyle habits 100%, because we know that testosterone is a marker of overall health too. So quitting smoking, making sure that your cholesterol and your lipid panels are normal, making sure that your insulin and your glucose control is at a normal range, and that you don't have, if you have diabetes, that you're keeping it as best controlled as you can. We've actually have studies that show in patients that are diabetic, if you do nothing else but treat patients that are diabetic and hypogonadal and you normalize their testosterone levels, doing nothing else alone, it will improve their hemoglobin A1C, which is a marker or a 3-month marker kind of range of where their blood glucose levels have been. And it decreased patients' insulin requirements. So I don't know any medication that can do that better. Maybe some of our new Ozempic and these new semaglutide, medications, but testosterone is a really important hormone, and it regulates so many important things. So again, keeping your body overall healthy, losing weight is great, but I don't think that should negate starting someone on testosterone who has low testosterone. Otherwise, it really is like you're telling them to go an uphill battle, pushing a huge boulder without having their testosterone levels normalized.
Yeah. And you mentioned earlier, like when you start replacing it, like it's going to stop the sperm production and everything. So if somebody's like teetering on that edge of low and they need that kind of boost to get in the gym, like the motivation or whatever, is there like a trial period that they could take it for a month and then kind of start having their levels up and then their motivation goes up and they go to the gym? You know what I'm saying?
Absolutely. So the AUA guidelines would recommend putting someone on testosterone therapy for a trial of 3 to 6 months. And if they say, hey, I didn't have any symptom improvement, then potentially discussing discontinuing the testosterone therapy.
Okay. The next question is from Jim. Why is there such resistance to testosterone level testing? I've had multiple men say that the doctors point out, oh, there is absolutely no reason to get your testosterone tested.
Again, I think this just goes to a long time ago, we had a lot of bad information come out. We had studies that were published in very important journals like JAMA and New England Journal of Medicine and The Lancet that came out that showed that testosterone was bad for cardiac health, or that it caused cardiac disease or caused heart attacks. And then we had data come out saying that testosterone caused prostate cancer to worsen. So I think it scared a lot of people off from prescribing this medication. Luckily, we now had a new study come out last year from New England Journal of Medicine called the TRAVERSE trial, TRAVERSE, the TRAVERSE trial, that actually showed that there was no increased incidence of cardiovascular events in giving testosterone therapy to men. And in fact, the population they used were men that had high-risk cardiac factors. And they used these high-risk cardiac men and showed that even in high-risk patients, meaning those that have had a heart history or high risk for cardiac disease, it didn't worsen that. It didn't cause any MACE or major adverse cardiac events. It also talked about others, they looked at prostate cancer, looked at many things in that study that we're able to get out of it. But I think one is bad data that had been published in the past. Number two, I think it's just a lack of understanding. It's not something that, in medical school alone that we get a lot of teaching on, that we're trained on or given information on. We're taught, that one testicle does the job of two, and that testosterone is for, getting big and strong and hair on your chest and helping with sex drive. So as people get older, they say, well, you don't need that stuff. You're getting older. It doesn't matter about erections, or it doesn't matter about sex. And that's just ageism, and that's paternalistic. And we know that that's not right. I'm fellowship trained. So I did a urology residency that was 6 years. And even in my own urology residency, while we got a lot more training on testosterone therapy and hormones in men, it still wasn't the extent that I got in my fellowship training for male sexual and reproductive medicine. So again, if you're going to some random, a family medicine doctor who, God bless them, because they have to know a little bit about everything and they're helping take care of so many people, maybe that's not an area that was their interest. So maybe it's not something that they focused on and went to some conference and heard an updated lecture that talked about really the importance of testosterone and how it's so important for our cardiac health, not only for mood, energy levels, and increasing muscle mass, but for bone health, for preventing metabolic syndrome, all of these things. So I think a lot of it is A, the bad data, two, just a lack of education and training in the area. And three, that again, some people are kind of old school, back in that mentality where they just think that, as you get older, it's a normal part of aging. And it isn't. And it doesn't have to be for men or women.
Gotcha. Okay. And I mentioned Joe Schmo, urologist, earlier. What about like these commercials you see for testosterone, like going to these kind of just clinics? How do you feel about those just testosterone clinics, or I don't even know if that's what they're called, but.
No, absolutely. These men's health clinics, these direct to consumer markets that have just popped up everywhere. So we could literally have 5 podcasts on this. I have so many thoughts on them, but for time, I'm not a huge fan of these. Number one, because most of the time they're not even run by urologists or physicians in general. They're not even run by internal medicine doctors or primary care doctors. They're oftentimes run by, mid-level providers or nurses or people, maybe a podiatrist, someone who absolutely didn't even go to medical school and to learn about testosterone therapy, whatnot. So they're not run by people that are really the experts in that field. Number two, they oftentimes don't take accurate or complete medical histories, meaning they talk to a young guy and they don't ask about, or any guy, and they don't ask if fertility is important. Because as we mentioned earlier, when you give someone exogenous testosterone, it will shut down sperm production. And in some men, that could be irreversible. So they don't take a great, accurate medical history and they can't do a physical exam oftentimes, or don't. And then number three is that they don't do accurate follow-up. So when you put someone on testosterone, there's several things that you need to make sure you're doing. Number one, you need to ask about fertility. Number two, you need to make sure that they understand that this is considered a lifelong medication and that it is going to require routine lab work to follow a patient. Many of these clinics don't order lab work, or they get it once every couple years, or they treat patients with super physiologic levels of testosterone and get them, in the 1500s or 2000 range. Because I see these guys, they come into my clinic And when you're not checking labs on these patients, some important labs that we look for is your hematocrit level. And that's kind of a marker of like the thickness of your blood. But hematocrit is a really important marker. And we typically want that number below 52. And when it gets above that, you're at a higher risk for developing DVTs or clots. We also want to look at estrogen levels, right? Because if your estrogen level gets too high, just like in Clomid, it can predispose a man to gynecomastia or man boobs. When someone is on testosterone therapy, it can cause testicular atrophy over time in some men. And that may be a complaint, or that may be something that they weren't told about. And people have come to my office and they're really upset over this. And so again, I just think that you need someone that's really going to go over all the risks, all the benefits of testosterone therapy, monitor you appropriately, and ask all the questions that are important, again, like fertility and things like that, because you can really impact someone's overall health with testosterone in a great way, but you can also cause harm in not managing it appropriately. So that's my thoughts, my short answer on these men's health clinics. I'm not a huge fan of them.
All right. So you don't like the men's health clinics. Noted. All right. But you mentioned the atrophying, and I know that atrophy can be a sign of testicular cancer. Is it a cause? Like if somebody were to have those extremely high levels of testosterone and then their testicle starts to atrophy, is that like increase their risk of testicular cancer, or is that just...
No, and I'm not aware of any data that would do that. It really just shrinks testicular size. But typically when someone gets testicular cancer, it's a growth or a mass that they feel. So which is why it's so important to do those self-exams and check your balls. Very, very, very important. But I'm not aware of any data that would show that testicular atrophy is correlated with testicular cancer. Now, when we see someone like a patient that comes in to see me in the office for infertility or low testosterone, I'm checking and I'm doing a physical exam, and having testicular atrophy can show me that there's a production issue going on. So that may just kind of be another marker that goes with the whole picture, explaining to me or showing, maybe why their testosterone levels are low, or why they're suffering with infertility or have sperm parameter abnormalities.
Interesting. Okay. Jim also asks, it still seems to be fairly common for some men to indicate they're getting injections every 2 weeks, typically with a form of testosterone with a half-life of much less than that. This means that their values are all over the place. They go from too much to too little. Is there any literature that men can use to point out to the doctors a reasonable protocol?
Yes, there actually is a lot of literature. And we even did a study, my fellowship at Memorial Sloan Kettering, where we were looking at giving injections twice, once every 2 weeks versus giving it weekly. And you actually find that when you inject with, every 2 weeks, what ends up happening is you get these really high peaks, and then you get these really low troughs. So your total testosterone level gets below normal levels most of the time before you reach that mark where you're due for your next shot. And in order to keep it up that level, then you have to increase the testosterone dosing. So then these guys have super physiologic, very high levels of testosterone at their initial injection. Most injection therapies, use short-acting preparations like testosterone cypionate or enanthate. They're very common. I use testosterone cypionate all the time in my office. So your peak testosterone levels are typically reached, anywhere from 8 to 96 hours after you inject. And most of these have a half-life ranging anywhere from, 6 to 8 days. So that said, if you're administering injections every 2 weeks instead of weekly, again, you're going to get these super physiologic levels of testosterone during the initial days following your injection. And then it's going to be followed by maybe the low normal level, and then it goes sub-physiologic levels by the end of that 14-day dosing period. Now, your bioavailable testosterone levels may fluctuate even more, reaching, peak levels that exceed almost twice the upper limit of normal. And that fluctuation is primarily going to be due to your testosterone binding to sex hormone binding globulin, or SHBG, resulting in an excess of your non-SHBG bound testosterone or bioavailable testosterone. Now, although biweekly injections offer the convenience of, reduced administration, especially if someone's not a huge fan of needles, weekly injections really are going to provide more of that kind of physiologic sex hormone level and profile with minimal variability. You get a little more of a stable testosterone level rather than having all this variation. And that can also offer other advantages, right? Like minimizing excessive stimulation of erythropoiesis or red blood cells, minimizing that peak of hematocrit that we were talking about that can predispose someone to clot or DVT. There was a study that was conducted in 2021. And they actually showed that adherence to a lower dosage but higher frequency intramuscular testosterone therapy appeared to offer similar benefits in, raising your testosterone levels, total and free levels, while significantly reducing that risk of hematocrit levels rising above 54%. So again, it may be more convenient, and I think that's kind of maybe just some old school testing or training, but weekly really is better for many, many reasons.
Okay. That kind of leads to, I'll jump to the next question from Jason. What are the options for TRT, and as many pros and cons of each as you can give in a short time? I know, I think Dr. Glaucomflecken, we had him on here, Will Flannery.
Oh, yes.
I think he has some kind of gel or something, or he had a gel at one point. But he has daughters. So
Yes. So transdermals or topicals, which are going to be your gels, most commonly is either Testim or Androgel or Auxilium. These are going to be gels that you apply daily. They have to be applied daily. They can go anywhere on the back, the shoulder, thigh, or abdomen, depending on the different formulations, because they have different specifications on which body part to apply the gel. But most commonly, it's your shoulders, back, thigh, or abdomen. The important thing is that, the dosing is anywhere from, depending on what you use, if Axiron, if it's a pump or if it's the packets of gel, anywhere from 40 milligrams to 120 milligrams every day. Now, it's very important the application of this, because you need to wash your hands before you apply this. You should apply it to clean, dry skin, and you want to make sure that it is completely dry before you get your clothes on, which is typically 5 to 10 minutes that you need to let it dry. If you don't do that, you're going to be at increased risk for transference, which is one of the biggest side effects of the gels. Transference actually means that it can be absorbed by your clothing and can be in contact with someone else, like a female partner or young grandkids or children that are running around, and it can actually mess up their hormonal axis and be absorbed into their system. We actually have published literature on, young female babies that develop clitoromegaly because their dad was on testosterone gel and didn't realize, and it was transferring to the child. So there really is a real and significant risk of transference with these medications. It's skin irritation for some patients. Cost may be a factor for some patients. The benefit to a gel is that it's rapid onset. It's out of your system in the 24 hours after you put it on, and it's pretty easy to use. But I'm not a huge fan of gels, just because most people don't take the time to put it on correctly, and you really worry about that risk of transference. And there's so many of us, right, that either have young kids ourselves or you're around grandchildren and such not. So I think that that's really important. There's also a transdermal patch that's called Androderm. It's 2 milligram or 4 milligram patches. That's another topical thing you can use. You can put it on daily. The problem with these is, and most of my patients, I've never had a patient stay on it more than a year, is because you get these dermatographic irritations. So you get rashes and you have to move it each day. So you have these little red blotches that are all over your skin. So, I guess the benefit is that it's, again, easy to use and it's something you apply daily, but you really get those rashes and those irritations from having to move it so much. There is an intranasal gel called Natesto, and this is kind of one of the newer things on the market. Natesto ranges in dosing from twice daily to 3 times daily. I think they've now changed the guidelines where you can use it twice daily instead of 3 times. And it's a great option for patients that, and have no problem doing nasal gel into their nares. And it's also been shown in some literature that this is one of the very few exogenous testosterone therapies that will not impact spermatogenesis. And the thought behind that is that, you kind of have these higher peaks and troughs of testosterone levels during the day by administering it nasally, intranasally. And so it doesn't impact fertility the same. But again, the benefits to this would be, a rapid onset. It's not something that you have to apply daily on your arm or your body. So it decreases that transference risk, that it possibly preserves fertility. But, the disadvantages is that it can still impact fertility. There are some published papers that it did impact fertility in some men. You get a lot of nasal irritation, burning or runny nose, and some patients will complain of altered taste or smell. We have injectables, which we kind of talked about briefly already. You have your short acting and you have your long acting. Your short acting are going to be, again, that testosterone cypionate or testosterone enanthiolate. Typically, again, you want to apply this weekly. Most of the time you start at like 100 milligrams a week. You can certainly, some people go up to 200 milligrams weekly. The benefits to this is, you have a really good compliance. You can get it fairly cheap. It's something that you do just once a week, you think about. But again, disadvantages for patients that maybe are needle phobic and very uncomfortable. If you're not doing it weekly, you can have that high variability in your testosterone levels where you get a high peak and a low trough. Some patients will say that, injections tend to have higher rates of polycythemia or that elevated hematocrit levels that we have to work on. And then if someone, maybe they have dexterity issues, right? Like they're not able to use a needle to inject well. And then just kind of briefly, the long acting testosterone would be like testosterone undecanoate or Aved. And this is a every 10-week injection that you need to get done in the office, as opposed to these short acting ones that you do at home, with yourself at home. Aved is something that must be done in the office. It's 750 milligrams intramuscular of testosterone. When you first come in, you get one injection in the office, and then 4 weeks later, you get a second injection, and then it's every 10 weeks. The benefits to this is that some patients will have a little longer compliance because you have to think about it just every 10 weeks. It's a long-term or long-acting testosterone therapy. But side effects or disadvantages is you can get POEM or pulmonary oil microembolism with this. That's where you kind of get into this coughing fit. After you inject the testosterone, shortly thereafter, you get into this coughing fit. So us as providers and clinicians, we actually need to, part of the recommendations when you prescribe this to someone is you have to keep them in the office for about 30 minutes after you administer this to make sure that they don't have that and that they tolerate the medication well. Some people will also say that you can get higher rates of hematocrit, again, that polycythemia, and then insurance coverage doesn't cover it for all patients. And you can still, again, get these variable levels. And a lot of patients can be hypogonadal before they're due for their 10-week shot. And you can't get this shot too early or insurance won't cover it. So that's just kind of some other ones. Now, there's also a short-acting Xiosted, which can come in these auto-injectors for people that are very uncomfortable or nervous with needles. So those are all kind of injectables. Another option is subcutaneous pellets, and that's called Testipel. And that's where you have these small pellets of 75 milligrams testosterone, and you inject it once every 12 weeks, or at least that is how I administer it in my own office. So the dosing, you can go anywhere from 6 pellets up to 12 pellets on patients. You dose titrate it based on their first, but it's an office-based procedure where patients come into the office, and every 12 weeks we perform this procedure. I numb them, they get a little numbing shot, and we put it kind of in the upper outer quadrant of the buttocks area. It's a subcutaneous, so it is not in the muscle, it's in the subcutaneous tissue. And then they come back every 12 weeks to get another Testipel. The benefit to this is that, again, it's something you're one and done. You think about it 4 times a year, every 12 weeks, and you're good to go. It's long acting. It gives you really nice, consistent testosterone levels. I tend to have my patients get what's called a peak and a trough level. So 2 weeks after insertion of Testipel and 10 weeks after, and then that's how I titrate them. And most of the time when I get that peak and that trough, I see that there's really only about a 200 fluctuation, from maybe 900 to 700 or 700 to 500. So you don't get a huge fluctuation in that as well. Now, the side effects or disadvantages is that it is an office-based procedure. You could get an infection. Anytime you make an incision on the skin, you could get an infection. Making sure that insurance covers it. Depending on how long you're on this modality, you develop scar tissue or have little scar marks from where you have the insertion of the Testipel. And again, you may have some expulsion. Sometimes pellets can come out. It's not common, but it can certainly happen. So that's really kind of the main different types of your injectables. But luckily now we also have oral therapies, and I kind of mentioned those earlier. One of them is Clomid that we already kind of talked about and mentioned, but there's also an oral buccal called Striant. It's basically a pellet. It's 30 milligrams. You take it twice a day, and you just kind of put it up here in the buccal or the gum area. and it's rapid onset. It's very easy to use, but you can still get that gum or mouth irritation where you're putting it. And some people will also complain of altered taste with this, and insurance isn't covering it with everyone. And then now we also have these newer oral testosterone therapies that are actual testosterone, unlike Clomid, which, as I mentioned earlier, is that selective estrogen receptor modulator that's great for preserving fertility in men and stimulating your own natural testosterone. But oral exogenous testosterone modalities are anything from Jatenzo, Tilando, or Kaisertrex. And these are typically done orally twice a day, different dosing depending on which oral medication. They're very easy to use, right? It's just a pill you remember to take in the morning. You get rapid onset of this. But a lot of the side effects here is that you may, again, have some GI side effects. You can have headache. It really needs to be taken, twice a day. So making sure that someone remembers to take their medication, and increased hematocrit levels, polycythemia, or increased blood pressure, and checking that with patients. So those are really kind of the biggest ones. And as I'd mentioned, we had already talked about Clomid and HCG, which can also be used to increase testosterone levels. But I didn't talk about the dosing. Clomid is typically 25 to 50 milligrams that you take every other day. You can increase it to daily, to increase someone's natural testosterone levels. And then HCG is typically, it's an injection. So again, for patients that are needle phobic, this may not be a great option, but it's anywhere from 500 IU every other day to 10,000. But it is an injection that you do to help increase testosterone levels. Benefits is that it does preserve fertility and it can maintain your testicular size. So some people will see physicians that prescribe testosterone therapy with HCG to patients that are worried about testicular atrophy. But again, side effects, you can be irritable, you can have injection site pain. It's not always covered by most insurance companies, and it can be very expensive, ranging anywhere from $100 to $400 a month.
We've mentioned...
That's really, I'm leaving out one last one for completeness. There's aromatase inhibitors, kind of how we talked about when patients, if you have a lot of obesity in your fat tissue, we have aromatase that converts testosterone to estrogen. Well, we have oral medications that are also aromatase inhibitors, like anastrozole or letrozole. And these are usually weekly, and they help basically block the conversion of testosterone to estrogen levels, which thereby increase your testosterone levels.
Interesting. Okay. You mentioned insurance, and then you mentioned people who would be adverse to needles. So how much, do those kind of things play into these options? Is there a natural progression that insurance will say, no, you got to do X, Y, and Z before you get, the Testapel, or does that make sense?
No, absolutely. So good question. So most of the time, gels or injections, like weekly injections or gels, are going to be covered right off the bat. I tend to see most of the time, if I try to prescribe someone an oral testosterone therapy, depending again on their insurance, sometimes that will say, well, you must have failed another modality, another treatment option for testosterone before they get approved for that. Some of the alternatives in that case, if someone really is like, I really don't want to try anything else and I want to just do the oral, is that they do have these kind of cards or discount cards that these companies provide, in different compounding pharmacies. You can get it for, reasonable, cheap rates, like maybe $75 a month. And you can just pay out of pocket for it rather than having it covered with insurance. But it really is, as you mentioned, it's so dependent on what someone's insurance is. But there's really no stepwise fashion that I make anyone go through. And it really should be individualized, which is, again, why I'm not a huge fan of these men's health clinics that pop up, because it really should be tailored to that. Are you needle phobic? Are you someone that you could see yourself injecting weekly and you remember? Are you someone that is going to be reliable with gels, that you're not around young kids, or that you would worry about transference? Are you someone that would do great with Natesto, the nasal gel? So I think, again, it's really just asking patient preference, who's comfortable, are they able to inject, do they have the dexterity? As someone travels a lot, right? Like maybe that's going to be very uncomfortable to try to do Testapel or Avid because they're having to time their travel with coming to the office to get a procedure. And then also combating that with their insurance and which ones make you try something else.
Yeah, that makes sense. Regina asks, is there any correlation regarding age at the time of orchiectomy and extremely low testosterone levels after orchiectomy? My husband was 47 at the time of orchiectomy, and we were told that low testosterone levels and other side not kicking in to compensate was rare. I was wondering if it's more common in men who are older at time of TC diagnosis.
Well, again, I think when you're post-pubertal, we don't tend to see as much hypertrophy or growth of the testicle to kind of kick in and cover that. But there was actually a study. It was published in European Urology. Don't quote me on the date, but it was published in European Urology, and they actually looked at the long-term sequela following treatment of testicular cancer. And it was this national, multi-center, multi-institutional study, and they looked at over 1,000 testicular cancer survivors specifically. I believe the average age was in the 40s, and they had actually been treated, and they followed these patients for an average of 11 years. And they found that, even doing age-adjusted odds ratios for testosterone deficiency, that after treatment, it increased significantly compared to their controls. So, however, there was no significant differences in age-adjusted mean serum total testosterone levels when comparing all testicular cancer patients with all controls. So as you get older, is that a factor of you being older, or is it a fact of maybe you also have some more comorbidities, right? Like we have other things that are also going into play about how well our testosterone levels or how well our testicles can really ramp up and produce the testosterone that we need.
All right. And then Kathleen asks a multi-part question, and she's in Canada. So she says, we kind of touched on this. At what level should a young man consider testosterone support? Are there non-prescription supplements? And do you have a Canadian contact for endocrine help?
Yes, we do have several of our colleagues. Pippa Sangster is in Manchester, and she's fantastic, and she would be a wonderful resource. And I can also offline, I can give you a couple other names as well. But we do have several patients that we could certainly do. In Canada, we have Ryan Flanagan, who is excellent. He did his fellowship with me at Cornell and MSK, and he would be a wonderful resource as well. But there's several, and I can give you some names of these for her as well. But is there a cutoff per se? Well, certainly if it is below 300 per AUA guidelines, that is considered hypogonadism with symptoms. That said, I'm a sexual and reproductive medicine expert. So I don't just go by, you have to have a cutoff of 300, because let's say someone is 330, in the morning, then great, they're 30 points above normal. But we know that testosterone levels decline throughout the day. So I know that, by lunchtime, this person is already hypogonadal the whole rest of their day. So I base it, really based on what their symptomatology is and what their total testosterone level is. I err on the side of treating anyone that is symptomatic with a total testosterone level below 450. And if it is below 450, then I am happy to start them on therapy. And again, reassess 3 to 6 months later, how are their symptoms, how are they feeling, and kind of go from there.
Gotcha. Okay. And I'm just going to ask one personal question. We talked all about testosterone this time, which is great. I'll have to have you back on to talk about fertility, but this is a fertility question. My wife and I, when this comes out, will have just had a miscarriage 2 months prior.
I'm so sorry.
Thank you. As far as we know, it happens. But having had chemo, does that mean that my sperm could have been kind of bad? I mean, I'm almost 5 years out.
No, really great question. So we do know that there are some higher rates of DNA fragmentation or chromosomal abnormalities in sperm immediately following chemotherapy and radiation. Typically, we recommend when people are trying to conceive after they've had chemotherapy or radiation that they wait about 2 years. 2 years is kind of that cutoff. Some studies will say 1 year. Personally, in practice, I recommend waiting 2 years in most couples before we get a semen analysis and then trying to conceive. And that is because at that point in time, those levels should have reached very close to normal levels as comparing with someone who has not had chemotherapy or radiation therapy. Miscarriage is something that's so important. And again, I'm so sorry that happened, but it's something that impacts so many couples, and it's something that we don't talk about enough. And we don't talk about how it's okay and it's important to really grieve that and to seek support, because most of the time these miscarriages occur in the first trimester. And that's usually when a lot of couples haven't even told anyone yet, right? And so it's like they don't even have anyone to tell to get that support and that outreach. So, I really encourage you, to speak and thanks for sharing that with you, because you're normalizing it for other people. But most of the time it's just a fluke when that happens. The body is so smart and it recognizes that, hey, something doesn't look right. And that's the body's way of saying, let's start over and let's start fresh and let's do again. But it doesn't minimize the impact that has on patients. And know at 5 years out, you should not be at any higher risk of having any abnormal sperm than someone else.
All right. Well, thank you. And I'm glad to hear that. Where can people find you if they want more information? I know you're on Twitter. I refuse to call it X, but you're on there.
I know, it's so weird. I'm Dr. Helen Bernie on Twitter or Instagram or any of those fun things. But I work at Indiana University, and I'm the director of the Men's Health and Reproductive section. So I'm happy to see you guys. We do virtual visits as well, which are telephone or video visits for patients that maybe can't travel this far. And you can certainly reach me online. But thank you so much for having me. This has been really great. And hopefully this will help spread some awareness and education for patients, and they can seek out, a urologist or a men's health expert to help guide them wherever they are.
Cool. Thank you so much.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org. You can also follow us on social media at Testis Cancer. We're on Facebook at Testicular Cancer Awareness Foundation.